Thank you very much. And I give each of you a participation trophy for coming early for a pediatric session. So thank you. You are better people than the people who aren't here. So don't worry about it. Thank you so much to the organizers. It's a very meaningful conference for me. I think my in-laws, as you heard, my wife is a British Indian. And so I think once I see the pictures of me lighting the candle at the beginning and getting the gift is really meaningful to me. But I think it's very meaningful for everybody. So thank you, and thanks again for the invitation. I'm one of, I think, 5 pediatric gastroenterologists, hepatologists here. And this is really a serious issue. I don't know how much better to say than it's sobering. And it's really something that we just have to deal with. And hearing that conversation, Margaret, about what you guys are talking about, we've been talking about this for sure for 15, 20 years. And there is, as it is with most talk, no answers just yet, but really quite important. So I want to take this first talk as a means to, and I have my time, so I'm going to use my time, to really talk about obesity and the roles for MASLD. So really the obesity epidemic begins in childhood. This is where prevention should be, everybody. It's not wait until they come to your office and then they all of a sudden have pre-diabetes or diabetes. This is preventative medicine, is childhood. The epidemiology, and the last bit, which I really believe in, this coming freight train of problems as these patients age into adulthood. As you have already seen, you've seen younger people have more disease than they should in their 30s or 40s. And I think that this is going to just worsen. So is this a new problem? Completely not. Before I give you the year of this, by the way, we all know what a magazine looks like. When I show trainees, they have to remind them what a magazine used to be. But this was a Time magazine. Can you guess a year when this title, I love this title, Girth of a Nation. Well, look at the top right, Yeltsin. Okay, so Boris Yeltsin. So this is from 1995, which to me is not long ago, but it truly is. So here's what the US numbers are, and I don't even bother updating this slide because they're roughly the same, a little bit more. 5% obese adolescents in 1980, 24% in 2017, 38% of the obese adolescents have MASLD. And, you know, it takes research to figure this out. And so some research have figured out, and it comes in with the title of this news article from an AGA, that the root cause of US obesity is that too many Americans are eating too much. I'm not exactly convinced what sort of research was needed, but this is actually the cause. And we know this. And actually, it's because we haven't had an intervention to stop people from eating so much until recently with the GLP-1 agonist to really prove this concept quite strongly. So this is, I was going to give more of a US because the 2 talks from Drs. Chowdhury and Prasad are going to have more of an India focus. I'm going to really talk a little bit globally, but really not talk about India. But I want to let you know that, first of all, the increase of obesity is increasing worldwide. So if you look at the adults on the top bar, it's from 1980 onward, the same increase is going on in kids. And yes, there's a regional difference, but this is, on the right-hand side is a global map for boys and obesity. Of course, it looks like India is protected, but this is just nationwide data. I think that there's underreporting here, but you can see that this is a worldwide problem, okay? Not only a worldwide problem, but you all know this from a big country with a lot of people here, the same idea in the US. There's regional differences that have value to pay attention to. So what you might know in one region may not necessarily apply to others. And this is a map of the United States on the right. And the states that are down here, but also up here, there's a tracking of obesity that goes along with poverty, as well as other markers. But it's really a big national crisis. And then with the different ethnicities that we have in the US, the percent of children who are obese, it really is different. We see it much worse in Hispanic and Black children, okay? So the bottom line of this slide is regional data are relevant. What's different? So it's been a while since most of you have been pediatricians, so I want to educate you about some changes that have gone in with our world in pediatrics. On the left-hand side, and I'm sure you have these, we used to have height charts and weight charts on the same piece of paper, or it would be now all in the electronic medical record. Well, that's no longer combined, and there's a reason for that. And I'm going to get into that in this slide and the next. Number one, we have a BMI chart on the right, and you'll notice that normal BMIs for children here, this median value here at about age 6 is about 16, is really different. So we have to have BMIs that are percent for age. Very different, okay? So for example, this is the same 10-year-old boy with different BMIs. So a 10-year-old who has a BMI of 21 would be in the 95th percentile. A BMI of 18 would be healthy, okay, etc. And a BMI of 23 for a 10-year-old would be obese. But that's not the problem. The problem is this. The BMI charts, they're not good enough. We can't use them. And in fact, we have an extended BMI growth chart that's in every single part of our electronic medical records now because of the obesity epidemic. And here's just an example of one child that I followed since the age of 10. Here's his weights when he gets to be 14, 15, 16. They're at the top. I don't know whether this weight here is more than this weight or is it 20 kilos more. I don't know that. And what we've done now is we now have an extended BMI growth chart that's percentages. And I'll blow this up so you can see it, that we now talk about their BMI that's a percent of the 95th percentile. So that's how we record this nowadays. So the growth charts are different. Okay? That's a reality. Global prevalence in adolescence, similar idea to what I showed you for obesity, but here's MASLD in adolescence, about 4% in 1990, now closer to 5% in 2019, but quite a significant one. This is a worldwide group. Again, your regional things are important to pay attention to, okay? More interest in global rise. I think these are I think, quite interesting numbers, that the increase of MASLD from 90 to 2019 has really gone from 25% up to 38%. So we've heard this before. What about prevalence in the US of elevated ALT in children? This is a paper we published now over 10 years ago that showed roughly an increase from the late 80s up to about 2010, roughly about 10% of children have what we would consider to be MASLD. Well, this is worse now. The percentages, this is another paper that goes all the way up to 2018, and that it's gone much higher. This is from a Southern California group that has a higher percentage of Hispanic Americans. And they did a full incidence, and it went from 36 per 100,000 to 56 in this time period. Quite a significant increase. What I wanted to blow up was on the right-hand side with their ALTs, because I think this may be of value as you think about a high ALT from the age of 5 onward, what that means as you're starting to develop. There's really some epigenetic and some learned behavior that I would say, learned meaning cellularly learned and adaptable from having elevated transaminases early and fat deposition. About a third of these kids have ALTs more than 100, which in my mind is an easy number to use as someone who's probably at greater risk. So not a small number of kids. Here's some more data about teenagers, and the divisions here in the different colors are everybody in blue, healthy, overweight, which is 25 to 29, just to use easy numbers for BMI, and then 30 and above here, okay, for their ALT, all right? And the arrow is really the healthy for everybody. And there, in this group, it's about 10% here, but the increased ALT, 39% of obese teenagers have an elevated ALT. So even just a very simple, soft measure, but it is a measure that everybody can do, okay? So what? And as I alluded to at the beginning, we have younger adults with diabetes, liver disease, CV disease, and cancer. So this is an audience participation mode. Okay, so there are 5 numbers here from, let's choose this A down to E. Question for you. At what BMI does a 17-year-old, okay, this is coming into your world, a 17-year-old exhibit twice the risk of cardiovascular mortality by age 40? So in other words, what BMI? So I don't know if this is working, the polling, But if it's not, I will give it another 5 or so seconds. Well, I think you're voting like in a fake election, but it's okay. It's 26. It's the lowest number on the mark. Okay? And this comes from this study, which I find quite informative, from Israeli conscripts, which is both men and women at the age of 17, 2 million. And then they followed these with the electronic health record. Okay? So quite a nice study, New England Journal paper from a couple years ago. And so mean age 17, a little bit more men than women. And they followed cardiovascular mortality. Really interesting story. And it ends up being that if your BMI percentage is in the 50th to 74%, you still have an increased cardiovascular mortality for somebody whose BMI is below the 50th percentile as one. And it certainly increases all the way. If your BMI percentile is 85th percent, that's in pediatric world overweight, not obese. And 95th would be obese, okay? I'm going to ignore the signals for a bit. So what about being overweight in late adolescence and liver disease? Here's a paper from Scandinavia, which also has very good long-term studies about this. Uses a differentiation of adolescents with BMI of 25 as a dividing point. In the US, we can't do a study where there's more patients with the BMI less than 25 than greater than 25 like this. But you can do this in the past in Scandinavia. You have a greater percentage of having liver disease, obviously, just from being overweight. And we know this. But it's a lower BMI than I think we would have thought. What about risk of type 2 diabetes? This is a more recent paper from the NASH CRN, which had biopsy-proven NASH. And the real question here was, what is your risk of developing type 2 diabetes in this group? And bottom line is, with just 4 years of follow-up, it's 17% prevalence. And it's obviously worse if you have some more fibrosis. Okay? Well, that's diabetes. How about pre-diabetes in adolescence? Well, this is an old news article. It's certainly more than 1 in 5 adolescents are high. This is the percentages for teenagers, depending on their ethnicity. And a hemoglobin here, A1C of 5.7%. Quite striking. Teenagers, 18%. Young adults, 24%. And I'm going to skip the rest here. I can certainly share that. But bottom line to all of this is that if you have MASLD in childhood, you have a shorter lifespan. If you want to remember one slide from this talk, I want you to remember this slide. So this has value. It is relevant. And you really do have a cumulative event rate. It's much higher. And this is, again, similar study from Scandinavia, 25 years and younger with biopsies, median follow-up of 15 years. Here's their 20-year mortality rate. If you have MASLD, it's 7% versus 1%. And it's not just so-called, quote, simple steatosis is bland, as we know. It's not. That's a 5-fold increase. And if you have MASH, it's an 11-fold. Okay. So when you think pediatrics, you think genetics and epigenetics. And of course, we talked about diet and sedentary behavior as well. I'll talk about that in the second talk briefly. I think what's mostly unexplored is really the true contributions of genetics and epigenetics. We know a bit more about PNPLA3, but that's about it. I personally feel that there's an epigenetic imprinting that happens, and people have already identified this with obese mothers giving birth to kids who then have a certain dietary risk, that it already is perpetuated, and the kid is not at fault. They really are being hampered by their own genetics and epigenetic changes to be thrifty with all the food that's given to them. Okay, so I'm going to summarize now. This starts in childhood. It's not so new. It's certainly not a national problem. It's a global problem. There's serious individual and societal issues with different generations. Food choices are changing, as is daily sedentary behavior. It is different. Dr. Chaudhry alluded to this. I think these children are at future difficult to change metabolic compromise. And one of my goals in joining Arun in the group is to really try to stratify those at different metabolic risks early, which we may be able to find. And life expectancy will likely shorten. All of our great advances in sanitation, medications, and vaccines is already washing away because of this. It's increasing globally. Disease processes start early and persist. I don't believe this is a benign condition. National differences and regional differences are relevant. And here's some key unknowns I want to end with. Prenatally and in early infancy, I think these are untapped opportunities for intervention. Doesn't mean that we're going to starve our babies, okay? Nobody wants to do that. Everybody loves a fat, chubby baby. Who doesn't? That's not it. It's really recognizing those at greater risk because of this. And it's not the babies. It's the 2 to 5-year-olds. It's the kids who can't climb up on my exam table. And they're all not that big, okay? They may be a little big. And so that's really the, especially in this country and where there's such a great preponderance of lean MASLD, this certainly is something that's at risk early on. There is an intersection of genes and diet, which I'll talk about in the second talk, which really, there is something there with PNPLA3. And again, I think one of the great unknowns are epigenetics and imprinting, and I'm going to end here. Thank you very much.